Hi, welcome to our program. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma, and I want to welcome you to our program, Digital Slide Review and Sign Out. Our case today comes from the realm of soft tissue pathology, an area that we can all stand a good review on from time to time, and brings up an interesting differential set of considerations. So the patient is a fairly young woman in her 30s who's been found to have a mass on one of her lower extremities, accompanied by, on physical exam, some enlargement of the regional lymph nodes draining that particular area. So this sounds like it's likely a malignancy, although certainly some infectious and other inflammatory disorders can sometimes have that kind of presentation as well. But I thought it would be just interesting to think about what sorts of lesions might present as already having metastasized. Well, certainly carcinomas are by far the most frequent, and of cutaneous carcinomas, probably the two major offenders are melanoma and Merkel cell carcinoma. We know that most squamous cell carcinomas remain localized, as do basal cell carcinomas, rarely metastasizing to regional nodes. So those considerations are usually further down the list. And of course, you always want to be concerned about the possibility of lymphoma, either as a predisposing factor for the development of cutaneous cancers, or as something that is also involving the node. And then we come to the soft tissue tumors. Now, these are an interesting array of lesions that can present with stage 4 disease with involvement of lymph nodes. And it includes Kaposi sarcoma, synovial sarcomas, epithelioid sarcomas, probably one of the most frequent ones to do this, along with some of these further down. Angiosarcoma or rhabdomyosarcoma also can do this. Leiomyosarcoma and clear cell sarcoma also enter into the differential of considerations there as well. So with that in mind, the lesion was excised, and this was what we found. So here we see a subcutaneous lesion. You've got the skin down here. I suppose we could just rotate this around so that it feels a little bit more top down. And you see it's deep to the dermis, which ends here. And notice that it has this architecture of being somewhat nodular. It has some blue tissue over here, maybe lymphoid response down here as well. And then this zone of sort of fibrous capsular changes, along with areas of hemorrhage and so forth. And this low power image is actually quite characteristic of this particular lesion. So what are we going to find as we come into higher magnification? Well, apologizing in advance for some of the scanning marks and scan lines here. We see that there's a proliferation here of somewhat spindled cells with a bit of epithelioid morphology, maybe some associated inflammatory cells along with this. And here we see some degree of vasculature associated with that, with areas of maybe boxcar changes. So we might wonder about Kaposi sarcoma in a situation like this, or other, vascular neoplasms. But then as we, look here a little further, we see this rim. This is not a lymph node per se, but it is a fairly intense lymphoid response here, with even a small germinal center here outside this. So a variety of immunohistochemical stains might be performed on something like this. We also did some FISH testing in this scenario and found that this lesion had a gene rearrangement. It had a fairly low mitotic rate. It was not Desmond positive. It was not SOX10 or S100 positive. Didn't have any CD34 in it. But it did have this sort of angiomatoid appearance with these sort of dilated pseudovascular spaces here like this, where it's just sort of falling apart or forming a large sinusoid type of lesion. So the FISH testing came back, and that was confirmatory that we had an EWSR1 gene rearrangement, and that nailed the diagnosis for us as angiomatoid fibrous histiocytoma. This is a rather uncommon mesenchymal tumor, and it's still in this grouping with histiocytomas, but actually there's really no morphologic, immunohistochemical, or electron micrographic appearance to define this as being of histiocytic origin. It is a tumor that has variable behavior, sometimes just presenting as a mass and not behaving in any untoward manner, and sometimes, as in our case, metastasizing to regional nodes. It occurs over a broad age group from children up to adults, no sex predilection. And most commonly, we encounter it, as we do in this situation, as a mass in the extremity, and usually somewhat superficial, involving the superficial soft tissues rather than the deep tissues. It can occur on the trunk and in the head and neck as well, but more frequent in the extremities. And this histologic appearance that we've seen here with this fibrous capsule and pseudoangiomatous spaces may or may not have hemosiderin, and then this peripheral fibrous tissue and lymphoid tissue is very characteristic. So if you can identify that pattern, that will be very helpful. And to kind of help you do that, I added a couple of other reference slides here to the discussion, just to review this in other settings. So here's a nodule that was kind of felt maybe it's just a lymph node or something, but got excised. And here we can see same sort of features: peripheral fibrous capsule, a little bit of lymphoid tissue, these pseudoangiomatous dilated ectatic spaces. And then when we come into higher magnification, we see this epithelioid or spindled type pattern of somewhat histiocytoid cells, maybe a few giant cells, a few background vessels along with this. Not a particularly wild or pleomorphic process, but a mixture of inflammatory cells. The vessels are a feature, that's the angiomatoid component in the name, and then the histiocytoid cells. So there's the pattern repeated in that slide. Let's take a look at another slide. Again, you can see from low power, we have a fibrous capsule, we have some dilated vascular-like spaces, and maybe some associated inflammation. Here in this lesion, these are actually nodules of tumor, and the intervening tissue shows a very intense hemosiderin deposition. So there is some connection or overlap with some of the hemosiderotic tumors that can occur in soft tissue as well. But this pattern with the fibrous bands and the associated lymphoid inflammation, which you can see here, should steer you towards this diagnosis. And then, of course, you want to do the appropriate molecular tests if you have that capability. Although, generally speaking, I think that the morphology is fairly helpful, fairly diagnostic if you find those features. So just to reiterate some of the other things we might see, this, in terms of immunohistochemistry, there's really not a pathognomonic pattern. It can have a variety of expression of various markers, but none of these are, 95%. The only thing that even comes close to that is SOX9, which is not a widely available marker. In general, the proliferation rate tends to be low, and it's negative for many of the smooth muscle markers, other than Desmond, that can be positive. Calponin, CD34, S100, cytokeratins, myogenic markers, and so forth. But as indicated, the EWSR1 is the most commonly rearranged gene. And so if you've got that probe, you can do that FISH test. Or FUS is the other gene that sometimes is rearranged. And most commonly, these have a CREB family partner. So a CREB1 fusion marker might also be utilized as a helpful diagnostic or confirmatory test. In terms of prognosis and treatment, these are things that you want to get out. But where might we go wrong with this? Well, if the dilated spaces and the hemosiderin is overwhelming, we might mistake this for a hematoma. We might mistake it as a benign fibrous histiocytoma, but that usually lacks the lymphoid component that we're seeing here. Follicular dendritic sarcoma is more of a specialized diagnosis and could also have some overlap features with this, but would have more characteristic dendritic cell markers. Kaposi sarcoma, we've mentioned that clinically. And of course, this does not have the HHV8 as the Kaposi sarcoma would. Spindle cell hemangioma, again, lacking the lymphoid component, would have positive vascular markers. Inflammatory myofibroblastic tumor and intranodal palisated myofibroblastoma also would have different immunohistochemical profiles. So nice little case to review, a relatively uncommon lesion. Angiomatoid fibrous histiocytoma is our final sign-out diagnosis. And I hope that that's been helpful to you.